you all for joining us for today's webinar, Hepatitis C and the Female Patient, Reproductive Health Considerations. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar, which was funded through an independent educational grant from Gilead. Before we begin, I would like to share how you can receive continuing education credit for this webinar. In order to receive credit, you must take the pre and post test. If you have not yet taken the pre-test, please click the link in the webinar's chat box. You can also use this box to enter questions throughout the webinar, which our presenters will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from ARHP's education team with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre and post test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Drs. Jenna Kawamoto and David English, today's presenters. Dr. Jenna Kawamoto is a clinical pharmacy specialist at the VA Greater Los Angeles Healthcare Center, or VAGLA. Dr. Kawamoto earned her Doctor of Pharmacy degree at Creighton University in Omaha, Nebraska. She completed a PGY1 pharmacy practice residency at the VA in Roseburg, Oregon, and then completed a PGY2 fellowship in gastroenterology and hepatology at the VAGLA. Dr. Kawamoto has been involved in all steps of hepatitis C care, including screening, referral, evaluation, treatment, and follow-up care. She serves as a preceptor for rotational and PGY1 pharmacy residents. Dr. David English earned his undergraduate degrees at the University of California at Berkeley in German and Public Health, and his MD from the University of California at Davis in 2012. He was a resident at San Francisco General Hospital, UC San Francisco, where he worked in the Family HIV Clinic to obtain a concurrent HIV specialist certification, in the Refugee Medical Clinic, and the MINT, or Mothers and Infants Nurturing Together program through the Bureau of Prisons, providing prenatal, postpartum, and newborn care for federally incarcerated women. We're thrilled to have them with us today, and I will now hand it over to Jenna.
Thank you, Jessica. Good morning, good afternoon, everyone. Here's the names of our planning committee, and we have nothing to disclose. So the learning objectives for today's presentation, we're going to discuss sexual and reproductive health issues for women with hepatitis C. We'll discuss best practices in HCV management for pregnant and lactating patients. We'll learn to counsel patients with HCV regarding risk and benefits of HCV treatment during pregnancy and lactation. And we'll also communicate with patients about the importance of HCV screening, as well as implications of a positive antibody result, and effectively describe the treatment options and long-term outcomes. To start with a brief introduction to the hepatitis C virus, hepatitis itself is simply defined as liver inflammation. The most common form of hepatitis is viral hepatitis, caused by hepatitis A, B, C, or D viruses. Each virus has a different pathophysiology, resulting in distinct signs and symptoms. The most common form of viral hepatitis is caused by the hepatitis C virus, or HCV. HCV is an RNA virus from the flavivirus family and is the most common cause of chronic liver disease and cirrhosis in the United States. HCV is primarily transmitted by blood-to-blood contact, but can also be transmitted by sexual contact or perinatally. Stages of HCV infection can be categorized as acute, which is less than 6 months after infection, and chronic, which is persistence of viremia more than 6 months after infection. Both stages are usually asymptomatic. Fewer than 25% of patients acutely infected have signs and symptoms. Most are nonspecific, such as fatigue, nausea, headache, abdominal pain. Some patients may also present with jaundice. Most patients fail to clear the virus, making chronic infections common, and the chronic infections is what leads to continuous liver damage, which can result in cirrhosis, hepatocellular carcinoma, liver failure, and/or extrahepatic manifestations. Here we see the natural history of HCV infection. So after exposure, the disease progresses slowly over 20 to 30 years, depending on the presence of various risk factors. Of those who get chronic HCV, approximately 20% develop cirrhosis, and 25% of those go on to develop HCC or require a liver transplant. The NHANES data are commonly used for estimating HCV prevalence, but they likely fail to account for incarcerated and homeless populations, leading to an underestimation. When including incarcerated and homeless populations, 4.6 million are antibody positive and 3.5 million are chronically infected, as evidenced by HCV RNA testing. Demographically, people aged 40 to 59 are most likely to have HCV infections. When the general population demographics are considered, HCV prevalence is higher in Hispanics and the Black population. As the HCV-infected population ages, the slowly progressive nature of HCV infection is leading to a rising morbidity and mortality. Between 2003 and 2013, the HCV-related mortality increased by 6.2% per year, surpassing 60 other nationally notifiable infectious conditions, which decreased at 3.4% per year. The authors of this particular paper suggest that this is caused by a lack of screening and treatment, as well as difficult to treat patient populations, such as co-infected individuals and non-responders. In 2014, a meta-analysis of reinfection risks revealed that it was relatively low in most populations, but it did increase with increasing exposure to risks, such as IV drug use and co-infected individuals who may engage in risk behaviors. Screening for hepatitis C virus infection. So because the treatments available for HCV are now curative, effective, and safe, it is important to treat as many people with chronic HCV as possible. Ultimately, this will help to reduce transmission of the virus. The CDC, the USPSTF, and AASLD/IDSA have all issued new guidelines for HCV screening in the past 5 years. Outside of baby boomers, many other populations may need one-time or regular screening dependent on the frequency of exposure to the risk. Those who are previous or current patients who have injected or inject drugs should be screened once if they are abstinent, or regularly if they are continual users. Recipients of clotting factor concentrated prior to 1987 and recipients of transfusions or transplants prior to 1992 should be screened once. HIV-positive individuals should be screened at least once. Those at persistently abnormal alanine transferase or ALT levels should be also screened. In addition to the CDC recommendations, the AASLD/IDSA guidelines further recommend that intranasal drug users receive testing, as they are at elevated risk as well. Additionally, they recommend that those who receive unregulated tattoos be tested at least once. In the general population, HCV has a prevalence of about 1%. The prevalence is much higher in many other populations, yet these individuals are often likely to go undiagnosed. HCV prevalence is highest among the homeless population at 32%. HCV is also very high among the incarcerated population, as well as among Native Americans living on reservations. Furthermore, it is important to note that birth cohort may not have as much impact in terms of risk in these populations. HCV is common even in people born after 1965 in these underdiagnosed populations. There is poor awareness of HCV due to the asymptomatic nature of the disease. This is true even among the baby boomer population. The low awareness of the disease may decrease screening rates. When surveyed, only 51% of baby boomers knew that HCV was curable, and only 17% knew that there was no vaccine. Just over a quarter were aware that they were at higher risk than the general population. Patients were also unaware of the modes of transmission of HCV. Clinician counseling of patients is an important step in achieving screening goals. When visiting with patients who were born between 1945 and 1965, or patients with risk factors, clinicians should initiate conversations about testing. Improving knowledge about HCV complications, such as liver failure, increases the willingness to be tested. Also, improving knowledge that HCV is curable and has new effective treatment also increases the willingness to be tested. All diagnoses begin with an anti-HCV antibody test. If the test is negative, no antibody has been detected, and the patient has not been infected by HCV. For those exposed in the last 6 months and for immunocompromised individuals, further testing can be considered. Now, if the HCV antibody test is positive, this indicates that the patient at one time had HCV, but it is possible that it's resolved. To test for chronic infections, the clinician must proceed with HCV RNA testing. HCV RNA testing is required to definitively diagnose HCV. A positive test indicates chronic infection, and patients should then be linked to care. Now I will hand it over to Dr. English.
Hi, everybody. So now we're going to talk a little bit about some of the other areas of hepatitis C treatment specific to contraception and women's health. So first of all, in terms of contraception, there we go. So we use the CDC medical eligibility criteria, and this is some guidance that was put out that basically gives some recommendations for the use of specific contraceptive methods by individuals who have certain chronic medical conditions, so in this case viral hepatitis. And they define this through categories. Category 1 meaning no restriction. Category 2, as you can see here, where generally the advantages outweigh the risk or proven risk. And in this case, what we want to do is have careful follow-up monitoring. And then category 3 and 4, usually the risk outweighs the benefit and isn't recommended, but can depend on certain clinical factors. So here in terms of hepatitis specifically, if you look at the first row across the top for viral hepatitis, so including hepatitis C, acutely from infection within the first few months or with the decompensation or flare of chronic hepatitis C, you can see the methods listed here as category 1 and no restrictions, anything progestin only, including the pill, the implant, the IUD, or the copper IUD or the depot, which is a progestin injection, are okay no matter what. And then as you go across, for women who are already on the pill, the patch, or the ring, for continuation, this would be given a category 2, and mostly that comes from the recommendation that if these women were to get pregnant in this case, that would be much more harmful towards their health rather than continuing the method and the worry about side effects from that. However, to start these methods in women with acute hepatitis C or a decompensation or flare, it's not recommended in category 3 or 4 to start those methods. In terms of chronic hepatitis C that's stable or those that are a carrier and either resolve the infection, any method is category 1 and there's no restriction. In terms of specific treatments, which we will talk more about with the second webinar in terms of the medications and those details, there is one thing to note for this, and those containing ethinyl estradiol, including the combined oral contraceptive, the patch, and the ring, should not be given with certain medications due to potential for liver toxicity. This is from the package insert from the manufacturer, so that includes the Vicera pack, which is 4 medications, and then the other one that's related, which is listed there as well. Any of the other treatments can be used safely with any of the other methods, which we'll go over a little bit more kind of what that specifically means in a bit. In terms of general counseling tips, and this is for any patient, but in this case I think especially important, we're always going to be using active listening, and it's really important to clarify goals. And so when you're asking your patient, you can ask her questions like, how important is it to prevent pregnancy, or do you want to become pregnant in the next year? And if she says that's the most important thing and that's really the goal, then generally it's helpful to go to something called the tier-based method, which we'll get to on the next slide. You also can provide hands-on models for certain things, for the implant or the ring, to actually have her see it, kind of see what it looks like and what it feels like. And along with all of this, you don't want to really give any direct statements and not really say this is what you should do, and kind of leave it open-ended. And a lot of that's really just using your listening. One other thing with this as well, back to one of the points above, is we also, kind of in going with the tier-based effectiveness, often should share the typical use rates. So this is sort of more real world, kind of how effective these things can be, because there are a lot of things that can get in the way depending on the method. So for things like the pills have to be taken daily, forgetting or running out can be an issue. Maybe not having the method available, being in a different location, traveling and not having it till the next day, things like that. For acute illness, sometimes gets in the way, and just not wanting to take the medication or not feeling kind of well enough to tolerate it. So this is a chart here showing the tier-based method. So up on the top, we see the most effective or more effective methods, and that's defined by less than one pregnancy per 100 women per year. And then as you go down, so the opposite of the arrow, you sort of see the less effective methods, which tend to lead to more pregnancies. This is the typical effectiveness, and this is based on the WHO chart. In terms of what makes these methods more effective, it isn't so much that they're more effective in how they work, but because they're just easier to adhere to and use properly. So things like we mentioned on the last slide with forgetting or side effects, things like that. In terms of specific populations in women's health, for pregnancy and lactation, so for women with hepatitis C, a cesarean section is not recommended as the primary method for delivering their baby in order to reduce transmission risk. Even though the time sort of in labor and that membranes have ruptured does tend to lead to longer exposure time for the infant or the baby, there isn't really enough risk reduction in doing the C-section preventatively to reduce the risk. It is not recommended. In terms of treatment in pregnant women, most of these directly acting agents, the newer medications that we'll learn more about specifically in the next webinar, haven't yet been adequately tested in pregnant women, so generally it is preferred to wait. Among pregnant women that do have chronic hepatitis C, liver cirrhosis does not typically worsen during pregnancy, and for some may actually even improve. And we're not entirely sure why, but that often is the case. And then for these women that do deliver their babies, and if the infant does test positive for hepatitis C and has the infection, there are no known negative long-term effects on the infant's growth and development. And for these women as well, postpartum after they deliver, it is recommended to continue breastfeeding. Hepatitis C is not directly transmitted through breast milk and lactation unless there's exposure through cracked or bleeding nipples. If that's the case, then that could increase the risk since it is blood-borne and their infant is exposed to blood. And so here's a case presentation. This is Ashley. She's 37 years old. She's a former injection drug user. She comes to the clinic at 3 months. She's pregnant, and this is her first prenatal visit. Reviewing her history and identifying the former injection drug use, We discussed the hepatitis C risk, and she agrees to screening, and she has both the initial antibody test positive as well as the RNA. Her initial labs, she has an ALT level of 22, an AST of 21, her platelets are 210,000, and her INR is 1.0. So keeping in mind sort of this scenario of her identifying risk factor, her history, and current pregnancy, and these lab values, how do we counsel her? We'll come through some of these points as we go through. So in terms of treatment, this is in general and especially important in these patients and discussing it with them. The goal is what's called a sustained virological response, which is an undetectable hepatitis C RNA level after 12 weeks of, this should say actually completion of treatment, not at the end of treatment. So 3 months after the last dose is taken. Along with this, and what we're really getting at in terms of what sort of more patient-oriented is that we're preventing progression to cirrhosis. Other things about this are interferon used to really be the standard and the only medication available. Now it's no longer preferred and discouraged and very rarely needed. And these new all-oral direct-acting antivirals, or abbreviated DAAs, have really kind of changed the paradigm in how we think about and treat the infection. In terms of pregnancy and the medications, there aren't great studies so far, but are generally listed as category A with some exceptions, mostly because there aren't studies that show any evidence of harm so far. This is ongoing. There is one medication which is category X, which is not recommended under any circumstance and contraindicated. There is definitely known fetal effects and teratogenicity, and that's ribavirin, which isn't a first-line treatment anymore. In terms of lactation, for women who have delivered and are now postpartum, not a lot of data on this as well, but generally considered safe, and as we kind of mentioned above, for women who are on treatment as well as with hepatitis C chronically, we do not discourage lactation. And here's some numbers for each of some of the common medications and some of the components and some of the combos. And as you can see here, based on these pharmacokinetic studies, most of the metabolites or the actual drugs are bound to maternal plasma and do not actually cross into the milk supply and are not passed on to the infant. So based on that, we think this is safe. General kind of preventive care counseling for patients. We should always discuss alcohol and that they should abstain because alcohol can worsen fibrosis and increase the risk of hepatocellular carcinoma. And 50 grams or more per day is sort of known to be related to progression of fibrosis to cirrhosis and higher risk for hepatocellular carcinoma. But the use of alcohol does not worsen the outcomes among patients that are being treated and is not an evidence-based reason to withhold treatment. Often insurance will sort of come back when you try to prescribe this and say they're not a treatment candidate because of it, but there's no evidence that that's actually true. They have pretty similar cure rates and do just as well. Along with the initial evaluation, we do also want to screen for co-infections because of shared transmission risk, being blood. There's a lot of overlap with other infections like HIV and hepatitis B. We also screen for hepatitis A, which is not bloodborne, but if that infection is something they're predisposed to due to lack of immunity on top of hepatitis C, they could be at worse risk of progression or poor outcomes. You can see some of the numbers here in terms of the worldwide prevalence, and then the smaller numbers between categories show the overlap for those two co-infection populations. So for hepatitis C and hepatitis B, estimated between 3 and 13 million as an example. Among those that do have co-infection with either hepatitis B or HIV, there is some worse overall prognosis. And among women living with HIV as well as hepatitis C, having hepatitis C regardless of anything else in terms of their health is seen as an independent risk factor for mortality. In terms of counseling and sort of prevention along with this, we are making this diagnosis and therefore responsible for educating our patients on how to prevent the spread or transmission of hepatitis C. So for a lot of patients, this does focus on blood contact. Some sort of bigger groups that are targeted generally are men who have sex with men, and we should counsel them on safer sex practices. The same would apply for women as well. They have multiple partners or engage in anal sex. They do have some higher risk for transmission to their partners. And this is a great resource here through the Harm Reduction Coalition. There's a link there which will be available for some great resources on counseling and more specifics of transmission risk and how to discuss it with patients. Among those being considered for treatment, there are a lot of barriers to this care. One big one is cost. Insurance coverage varies tremendously from patient to patient. Some have no trouble and some have multiple barriers to try to actually get the treatment approved. Often insurance will do things like have these policies that insist that patients are abstinent for more than 6 months, that they have invasive fibrosis staging, that they haven't used any injection drugs for 6 months, and that they're limited to only one lifetime treatment course regardless of anything else. Among these kind of common barriers that are given, in terms of the alcohol abstinence, there's studies that show there's no effect on the cure or sustained virologic response outcomes. For the invasive fibrosis testing, there's studies showing that invasive compared to non-invasive testing, meaning things like biopsies or scans compared to just lab review, don't really correlate well and aren't necessary. And also studies show that even among those with some active drug use, injection drug use, they can still have a cure. More importantly, the cost-effective analysis for this Hep C treatment and the new DAAs still shows that it's ultimately more cost-effective than the old interferon-based treatment. A lot of this has to do with the quality of life years gained for patients and the reduced morbidity and mortality from things like advanced and decompensated cirrhosis, hepatocellular carcinoma, need for hospitalizations and transplants. There is also a tremendous socioeconomic status and race component to this and the disparities among the Black and Hispanic patients that are infected with Hep C. They're less likely to receive the treatment. Hispanic patients had the highest rate of cirrhosis, sort of proportionally to population, but the second lowest rate of treatment. In one study that was large, the Black patients with hepatitis C overall were more likely to be deemed treatment ineligible when compared to white patients. They often were not given the option for treatment. It wasn't discussed with them. One specific study found that 40% of Black patients were deemed ineligible compared to 20% of whites. Some of the reasons given or sort of identified in this study were that they tended to have more abnormal hematologic values or pre-treatment testing. There was concern for toxicity, abnormal liver or kidney testing as well, uncontrolled or poorly controlled diabetes, and other pre-existing medical chronic comorbid conditions. Among those Black patients who were treated, they were much more likely to be lost to follow-up when starting treatment. And then lastly, overall across all races and ethnicities, socioeconomic status is also correlated negatively with hepatitis C testing and access to care. Other barriers include adherence to the treatment and engagement. So some patients are often reluctant to receive treatment because they maybe aren't quite sure about the duration, which is somewhere between 8 and 12 weeks for most of the medications, or the cost. Those patients that are engaged and educated are more likely to adhere to treatment, And when we look at the numbers and data for cures, they do vary from the clinical trials compared to real world, but a lot of that probably has to do with just the issues that patients face. And so one way to engage them and encourage them to stay in treatment and to continue and finish and have the cure is going through a set of questions to sort of find out how to better support them. And a great resource is listed here. It's called PrepC, and it's a website that you can go to and sign up for, and goes over all the different areas and how to support patients through this. Another big reason, unfortunately, is that there are provider-driven reasons. A lot of clinicians worry about reinfection, especially among those who are injecting drugs, and are much less likely to prescribe treatment. Reinfection after a cure does occur, but it is very low incidence. And also, among those who are actively injecting drugs, a cure in the SVR is possible based on a lot of large studies. Now you can see here from a survey that there were many clinicians unwilling to treat patients who injected drugs or those who have not been abstinent for 12 months. And this is against evidence-based guidelines. And you can see here that almost half of all providers will not treat IV drug users, even after 12 months of abstinence. And there's no evidence or recommendation for this, but real world often is happening to patients. So back to a little bit of the specifics for pregnancy. In terms of counseling during pregnancy and risk of transmission, for those children who are born to mothers with chronic hepatitis C, testing is recommended for the infant, and the definitive diagnostic test is recommended between 15 and 18 months. And some risk factors in terms of prenatal transmission are the higher the maternal viral load for hepatitis C, the higher the risk, prolonged rupture of membranes, any active maternal drug use, and then anything that sort of exposes the infant to maternal blood, so operative deliveries using forceps or vacuums, things like a fetal scalp electrode placed onto the fetal scalp can cause some bleeding. And in terms of healthcare workers, which would apply to pregnant women working in healthcare or public safety, after a needle stick or any mucosal exposure to patients known to be hepatitis C positive, it is recommended that they be tested after 6 months since that exposure. So here's Ashley. Results. She had a hemoglobin of 11, hematocrit of 32, platelets of 230,000, INR of 1.0, ALT of 22, AST of 20, and a creatinine of 0.6. These are normal values for her at this point in pregnancy. It's discussed with her and recommended that she not begin hepatitis C treatment with DAAs until after the birth of her child. And in discussing with her the concern for risk of transmission to her fetus and infant, we discussed that the risk is not improved by doing a cesarean section. And we discussed with her as well that she should start treatment as soon as possible after birth, since we know that it's considered safe during the postpartum period and during breastfeeding. If the baby does test positive for hepatitis C at 15 months, we'll discuss with her as well that there's no known adverse long-term effects on the infant's growth and development. And I believe it's time now for any questions.
Great. Thank you, Jenna and David, for that excellent presentation. We will now begin taking questions that have been entered into the question box. And I'll start reading those right now. So far, we don't have any questions based on the content. So if folks want to enter those into the question box right now, we will address those in real time. Are there any questions that you two receive frequently from your patients that it would be helpful for other physicians to feel prepared for?
I do see the question about sort of eligibility for treatment come up a lot. I see quite a few, actually young women that are coming into our clinic that are referred from sort of like post-incarceration treatment programs for substance use. A lot of them in their 20s and early 30s, and say, well, I was told that because I'm young and because I could get pregnant, I shouldn't get treatment. And I think there's a lot of that kind of misconception out there, probably because a lot of people are still thinking about hepatitis C from the days of interferon and safety, as well as the other kind of barriers that were mentioned, like cost and readiness and unstable social circumstances. These kind of, I think, create an especially difficult situation for these young women.
Great, thank you. That's a wonderful point. Our next question comes from Marianne, who asks, should everyone be offered treatment, or is there a threshold of LFTs or other criteria?
Yeah, that's a good question and often comes up a lot as well. The official joint guidelines from the IDSA, which is kind of the ID Specialist Society, and the Liver Society, the AASLD, essentially say anyone is treatment eligible as long as they are not sort of with facing a terminal illness. And meaning, would you expect them to die within the next 6 months, which is a pretty narrow patient population. So that essentially means everybody is treatment eligible in this case.
Great, thank you. Jenna, anything to add?
No, nothing to add.
Thank you. Our next question comes from Myra, who asks, is the reduced risk of reinfection after SVR related to behavior change or some protective effect of antibodies or other mechanisms?
I don't know of any specific studies looking at this question, but most do tend to think of it in terms of behavioral reasons. So things like sort of whatever the risk factor was before, say needle sharing and injection drug use, things like that may continue, and most of the reinfections come through things like that rather than things related to the person's health or immune response or ability to clear infection spontaneously.
Great, thank you. Anne has asked our next question, and she asks, I work in a rural hospital without quick access to a NICU. Would you recommend an HCV-positive mother not deliver in such a setting? And parenthetically, are there any increased needs for medications, etc., for newborns born to HCV-positive moms?
Yeah, it's an interesting question as well. In terms of hepatitis C, there isn't actually anything treatment-wise or intervention-wise needed for the infant. The main thing that we need to do in that case is the counseling for the mother, and that really means sort of ensuring that she knows she can breastfeed and should if she wants to, and to let us know, for us to check for any signs of blood exposure to the infant, so bleeding or cracked nipples. In terms of needs medically for the infant that would require a higher level of nursery care, there wouldn't be any in the neonate, and actually not for quite a while, if at all. Really the next step, other than the counseling right after delivery, is to do the infant testing at 15 to 18 months for the antibody. And even then, if they do test positive, sort of in terms of treatment, it isn't always necessarily recommended then, and that's definitely a point where help would be needed, but quite a ways down the line from delivery, if at all.
Great, thank you so much. That's a great question. Our next question is from Elizabeth, who asks, is it necessary to do any further investigation for a patient who has a positive antibody screen but a negative viral load?
Usually for, if the antibody is negative and the viral, or positive and the viral load is negative, then there is no further workup necessary. That could mean that that patient was exposed to hepatitis C, but they're in that 20% that spontaneously clears the virus. However, if the patient is, say, immunocompromised, then you could possibly, actually no. But then, so say like someone, you test positive for a antibody but negative for HCV. I've come into situations where say life insurance doesn't want to give you insurance because your antibody is positive, meaning you've been exposed to a high-risk behavior. Then you could do a more specific, the RIBA test, and that can test for, or the ELISA test, that tests for false positives antibody.
Perfect. Thank you, Jenna. David, anything to add?
No, but I have heard that come up as well, and it can be really tough to, I guess, figure out why that may be. Had a few patients come in with no identifiable risk factors, denied every kind of behavior associated with Hep C transmission and still tested positive, and it can be pretty stigmatizing for some patients because they're sort of, in their mind, they think seen as people who use drugs or people who have a lot of sex partners or engage in sex work, things like that. It can be either false positive, like Jenna mentioned, or maybe something related to something at birth or a blood transfusion, if it was before screening was done, things like that. Can be very tough for patients, definitely.
Thank you so much. Donna has two questions for us, and her first is, what are the major side effects of the DDAs?
Sorry, can you repeat the question?
Absolutely. The question is, what are the major side effects of the DDAs? Does that make sense?
Okay, yeah. So the major side effects of the DAAs is one big side effect is fatigue. Another one is headache. Patient may experience some nausea, insomnia, but that's pretty much what I counsel my patients on. But yeah, mainly it's the fatigue and the headache. But with the new, like Epclusa, the sofosbuvir, and one of the newer ones that's coming out from Gilead, the sofosbuvir, because I don't know what's the reason, but probably because it has a protease in them, I see more nausea.
Great, thank you. The second question is continued lab testing needed for determining resolution of the disease?
There is, yeah. That's essentially what we're getting at with the SVR, or the Sustained Virologic Response. That's kind of the standard in terms of testing after treatment completion. And those that have the SVR, meaning they have no detectable hepatitis C viral load 12 weeks after they complete treatment are considered cured. If they continue to have a detectable viral load or a rising viral load, then further testing definitely is needed, and that's often the case where they're referred to a hepatologist or liver center. They may need more complicated treatment, or this may be a patient that then would need something like the older interferon treatment that can depend on a lot of factors. So really the only testing needed after treatment is that hepatitis C viral load.
Great, thank you so much. Paul asks, do you have tips for patient communication to reduce the stigma of an HCV diagnosis?
I think that's a great one, yeah. I think like a lot of things that we see, and I think about it a lot like other issues we deal with in reproductive health care, so things like STIs. You have a patient that is diagnosed maybe unexpectedly with gonorrhea or chlamydia, something like that. It always goes a long way, I feel, to, or can go a long way, to really normalize it and explain that it is very common and this affects millions of people every year. And it's something that's there and there's often no way of knowing. And finding out sort of what their concern is, I think, as well. For some, maybe they know somebody that had hepatitis C or somebody that had cirrhosis or maybe even died from cirrhosis. Fear is a big part of it. Or maybe being seen as sort of like that other person if they were maybe someone who was also stigmatized. I think just exploring sort of what their worry is about it or what they think it means really can make all the difference in this.
Great, thank you. That's really helpful. Rhonda asks if you anticipate any new recommendations to screen all pregnant women for HCV in the future, as long as rates of infection are pretty high? Or do you anticipate any other changes to the screening recommendation?
Yeah, I think that's a good question as well, and something I see a lot where I'm working now in New York and teaching the residents and sort of who should be tested and who shouldn't. I think it really just depends on sort of your pretest probability, depending on where you work. If you're in a clinic that tends to see more hepatitis C infections, regardless of age, gender, race, whatever it may be, you're more likely to do it. We don't routinely do it on all pregnant women, but I find that often we're doing it because we do identify a risk factor. That may change at some point, I don't know. I think partly don't routinely screen for it in all pregnant women right now because there isn't really much that can be done during pregnancy and right postpartum in terms of preventing transmission, as opposed to something like hepatitis B. All pregnant women are screened because they can get the immunoglobulin and vaccine for the newborn right away to prevent their chance of exposure and infection. So I don't know for sure if it will change. It may, but I think as of now, just go by risk factors. But I do think all pregnant women should be asked the questions for screening. That's, I think, not routinely recommended, but should be, and maybe at some point become the standard as well. That's where we can really make the impact.
Great, thank you so much. Those are all of the questions we have for right now, but if folks on the line think of other questions that they would like to have answered, please do feel free to email us at education@arhp.org. David, would you like to go over the key points now? David, you might be on mute.
There we go. Sorry about that. So some of the key takeaways are many people, including women, living with hepatitis C are unaware of this, and we are responsible for knowing what the risk factors are and how to discuss with patients sort of screening and testing. The older interferon-based therapies are no longer preferred, and the new directly acting agents with and mostly without ribavirin are the preferred treatments. Cost, access, and provider willingness are all huge barriers to care, and we should be working on making strides to ensure that the access to this care and the DAAs is equitable. And lastly, some of the special patient populations may require different treatments.
Great, thank you so much. And thank you again for joining us, Jenna and David. Before we end today's webinar, I just have a few additional reminders to share with everyone. We do invite you to visit ARHP.org and register for Friday's webinar on HCV screening and treatment for male patients. ARHP.org is also where you can view a recording of today's webinar, and you can also download PowerPoints of both of these presentations for your future use. As an additional reminder, you will receive an email from the ARHP education team in about an hour containing a link to the post-test survey. Your CME nursing CE certificate will be generated at the end of that survey. Please be sure to print the certificate before closing your internet browser. If you have any questions, just feel free to email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.